Welcome and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing webinar series. During this webinar, participant microphones have been muted. However, we do encourage you to make use of the chat box to communicate with the presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. We are also pleased to share that this webinar series will be extended by 4 sessions and is now concluding on July 1st. If you would like to submit an operational topic for consideration for a future webinar, please write to us at ready@savechildren.org or use the chat box during this and future webinars. It is now my pleasure to introduce our moderator for today. From the Center for Humanitarian Health at the Johns Hopkins Bloomberg School of Public Health, and the Emergency Response and Recovery Branch at the Centers for Disease Control and Prevention, we welcome Mija Ververs. Welcome, Mija.
Thank you. Welcome everybody to this webinar. We are grateful to have you all online and we hope you'll have an engaging hour. First, I would like to introduce Sarah O'Flynn, who is the Director of Emergency Nutrition from Save the Children. And Sarah and I prepared this webinar and she will lead the Q&A session a bit later today. During this webinar, we'll have one main speaker for approximately 15 minutes and 2 additional speakers sharing their additional thoughts for each about 7 minutes. Afterwards, we will engage in a discussion. 2 weeks ago, The Lancet published a study from a group at Johns Hopkins that modeled indirect effects of the COVID pandemic on maternal and child mortality. They estimated that because of the potential disruption of health systems and decreased access to the food, and the prevalence of wasting will increase substantially in lower and middle income countries due to COVID. We know that the pandemic is straining the food systems in Africa, but also beyond. South Sudan, Nigeria, and Yemen have currently an acute food insecurity crisis. The pandemic has affected food supplies globally. It has affected cargo movements. It has caused export bans for staple foods in some countries. And of course, we will eventually see the impact of reduced vaccination coverage in many countries. I've now the pleasure to introduce to you our main speaker, Ms. Alison Omenlawi, Deputy Divisional Director for Nutrition Operations, Analysis and Integration at the World Food Programme. Alison has worked for WFP for the last 6 years as the Senior Regional Nutrition Advisor for East, Horn and Central Africa based in Nairobi. She began her nutrition work in '96 with MSF in Uganda. Alison's last position before she joined WFP was at UNHCR, where she was the Nutrition and Food Security Advisor for the East and Horn of Africa for 6 years. We're happy to have Alison with us, and she will talk about the impact of COVID-19 pandemic on nutrition, food security, livelihoods, including food prices and the dietary changes for households. I will introduce the additional speakers after Alison's presentation. Alison, the floor is yours.
Thank you so much, Mija, appreciate it. Okay, fantastic. So let me make sure I'm sharing my screen. Ryan, are you able to see this?
Sorry, no, not yet.
Huh. It shows that it's working on mine.
Here we go.
How about now?
Looks great.
Okay, excellent. Thank you, everybody. So I want to talk a little bit about nutrition and food security in the context of COVID-19. Specifically, I'm interested in talking a bit about how unaffordability of healthy diets and access to food is going to fundamentally impact nutrition. Let me just get myself situated. So as you guys are well aware, the Global Report on Food Crisis put out their 2020 report. This was a joint analysis that was done, and what it told us was that 135 million acutely food insecure people are anticipated to be in crisis or worse in 55 countries and territories. The main drivers of food insecurity, as we all know, of course, are conflict, but also intense weather events and economic downturns. So that was the situation pre-COVID, already going into 2020. What then happened is that we, at WFP, we sought to do a food insecurity projection to try to understand what the impact of COVID-19 would be on the already vulnerable populations. And two main pieces of work were used to do this. One was looking at ILO job statistics about job loss. This is just the loss of the labor market and what was going to happen with COVID if people couldn't go about their daily work, if they weren't able to either reach their places of employment or if those places of employment were to shut down. The other big driver that the food insecurity looked at was around remittance loss. As you know, huge swaths of the most vulnerable parts of the world, people to meet not only their daily needs, but in particular their food needs. We've in fact seen a recent statistic that said that Africa could face up to a 20% reduction in remittances. So looking at job loss plus remittance loss, we were able to model in WFP that there could be an additional 130 million people that were anticipated to be food insecure due to COVID-19. This is in addition to the 135 that were already projected in the Global Food Crisis Report for 2020, leaving us this whopping figure, very daunting, of 265 million people in acute food insecurity in 2020. So one of the things that we've been looking at WFP is wanting to understand, of course, this idea of how these COVID projections of digits. And there are a couple of different ways to look at that, but one of the ways that we did that is to use some modeling that is called Fill the Nutrient Gap, that looks at what the prices of a diet are for different population groups and different members of that household. And what we really looked at was the number of people that were unable to afford a nutritious diet is anticipated to increase. And in fact, women, children, and adolescent girls will face the greatest challenge. Two places where we were doing some projections were in Rwanda and in Burundi. The Rwanda baseline data came from 2017. The Burundi baseline data came from 2019. And as you can see on the left, what it shows is that there was already a range of up to 64% of the population that were going to be at risk of not being able to afford a diet. And this has now increased up to 72% at its highest level. For Burundi, much the same, that there's an anticipated increase in the number of people due to food prices and due to their own set economic abilities that are not going to be able to meet their food needs. So what we then wanted to think about a little bit is we've heard a lot about how the COVID-19 is very much an urban crisis. And the data that I showed you at the beginning that was around remittances and labor really was focused much more on the urban settings, where a lot more data has been collected on that informal and formal labor market. But what we are seeing is that there's a fear that the non-affordability of a nutritious diet is going to rise quicker and higher in the urban rather than the rural areas. And in fact, associated with that, individual in remote area without their own agricultural production could lose access to some of the few nutritious commodities that they were able to afford. So you'll see a little bit on the left of the changes in the non-affordability of a nutritious diet, again from the Burundi and the Rwandan examples, which are places that we had baseline data that we were able to do some projections on how that change was going to affect. So the real thing that we wanted to think about as well is, so you have these food insecurity issues, you have the economic implications, and we know that it's not going to impact every single region of the world equally. But one place that we have been quite concerned, and I'm sure everybody's concerned about, is in East Africa. Because what the stats are showing us is that already that the unprecedented economic implications of COVID in East Africa could double the number of people in food insecurity. From 20 million to 34 to 43 million, there always has to be a range, because when you do these kinds of projections, you're trying to understand how much the different factors might impact. So what we're looking at is that a lot of new vulnerabilities, new people that are going to be driven into extreme poverty in the East Africa context. So some of the things that are of particular concern is the high prevalence of poverty in slum areas, the fact I mentioned before that remittance inflows have dropped drastically, which is going to reduce the consumption, expenditure, and access to food. The fact is that spending by households will go down. Households have less economic abilities, and so their own spending goes down, and that has a ripple-on effect, especially for the informal sector. And of course, there still is this localized impact on farmers and livestock. So these are new vulnerabilities, but the problem with East Africa is that these vulnerabilities are being layered over existing shocks and existing vulnerabilities that are coming to East Africa. Already, as I mentioned, that huge figure of an additional 135 million people having nothing to do with COVID, this is because of conflict, because of drought, locust invasion, and flooding. So East Africa is getting hit with multiple shocks at the same time, and now this economic impact is coming on top of that, and that's, of course, a huge concern. Another place that we looked that was quite interesting is in January 2020, we finished some modeling that was being done in Afghanistan. And this was done in December 2019 into January 2020. And in Afghanistan, what we found is that a diet that meets energy needs only was only affordable for 1/3 of the Afghani population. Now, this is still pre-COVID, but we also found that 85% of the population in Afghanistan wasn't able to acquire a diet that meets all of the nutrient needs. So the previous slide was looking at energy needs only, and that's 1/3 of the population. But when you actually look at an affordable, nutritious diet for a population, 85% of the population, even before COVID, was having trouble meeting their needs. And what, of course, the concern is that now in Afghanistan during COVID, that I think everyone saw the BBC headline of coronavirus, 7 million Afghan children at risk of hunger. So what we're looking at in Afghanistan is a great example of understanding that those who were already hungry are still going to be hungry during COVID because of the extreme economic collapse. But that those that were just at the borderline are no doubt descending now and not being able to afford a nutritious diet. And the sad thing is that this is not just even an acute impact.
Hi, May. It looks like we might have lost Allison.
I see we might have lost Allison. No, she's back. Allison is on mute. Allison, you're on mute? Or okay.
If I can unmute, though, it said
Yes.
muted by the owner. Okay.
Okay, you're back. Go ahead.
Okay, thank you. So now I'm just having trouble going forward to my slides. So a food systems approach to nutrition is one way to look at nutrition and to give us a good idea of what kind of impacts we can expect when the food system collapses, like we're seeing in a place like East Africa or in Afghanistan, and how that's going to impact on nutrition. So of course, not to give you a lesson in food systems, but we look, of course, at the supply chain and optimizing the supply chain and the retail offers. We look at the food environment and how we can increase and diversify home production of nutritious foods. We look at consumer behavior, which is a really important aspect to understand how consumers interact with what's available in the markets and how they spend the money that they do have on meeting a nutritious diet, on feeding their stomachs, or on the myriad of other needs that a family has. And that even when we can support for a voucher, that still, we're going to have to look at what's available, what the diet looks like, and that's going to have a major impact on nutrition and health. So some of the things that I think that are sort of obvious now is that we're looking at two different pathways around food security and nutrition outcomes. We have the direct impacts of COVID-19 that Kate's going to talk a little bit more about, adaptations and how you actually work when there already are malnourished people. So
Alison,
we know that COVID is impacting on malnutrition diet.
Alison, may I interrupt you for a second? Sorry. People would really love to see your slides, and we suggest maybe that you turn off the video and put on your slides. Try to put them back. People really would like to see your slides.
Oh, you can't see the slides?
No. So if you turn off your video for the bandwidth reasons.
Oh,
yeah.
Absolutely, no trouble. Yeah. Okay. Sorry, I had no idea. Okay. So let me turn off my video.
Yeah.
There you
You're
go.
off.
Okay.
Nope.
Did that work? Almost. Stop video.
Yes, correct.
Yes. Okay. And now let's go back to the slides. Okay. Are we back?
Not yet. I don't see your slides yet. Ryan?
Sorry, everybody.
Yeah,
Ryan?
why don't I go ahead and share? No worries.
Okay. Sorry.
Okay,
Ryan, if you can go to number 12.
So go ahead, Alison. Ryan will put up the slides.
Okay, wonderful. Thank you very much.
Yeah.
Okay, so what we're looking at are the different entry points. And so we know that COVID is going to impact on malnutrition and diet. But response to COVID, which is of course a public health necessity, is also going to impact because of movement restrictions across and within borders, because of the social distancing, the physical distancing measures, and of course the closing of non-essential businesses, which is greatly impacted on the market. So if you look at the food supply, the food environment, consumer behavior, finally ultimately leading to diets, what you're seeing is that there's many different areas that those impacts can happen on the food value chains, on the livelihood strategies and the income, and on the food sources that have been restricted. And then fundamentally, as we're going to hear, the health systems are also strange, and that individual knowledge and behavior could lead to negative outcomes. We saw food hoarding, food choices, but also what people can afford when they go to the market. Ryan, next slide. Okay, and then the next one. Yeah, and I'm not going to go into any detail here because Alex is actually going to take us through assessment and surveillance, simply to talk about the fact that one of the things we really are encouraging governments during COVID is to really keep track of diet costs and diet affordability, because they give us so much information about eventually what the impact could be on the nutrition status of households who can't meet the economic needs to buy an affordable diet. So the availability and price of the set of foods, how expenditure and income, what kind of data we have on job losses, remittances, and then finally really trying to understand household data and food consumption during the crisis. Next slide. Thank you, and now the final slide. Thank you. And so when we get down to it, we have seen that we've led you through this idea that there's intense food insecurity. We know that that exists in many fragile parts of the world, regardless of COVID. COVID now has come in and exacerbated that food system. And now we want to figure out what is the best intervention. And this is something that governments and agencies around the world are trying to figure out. Is it cash? Is it vouchers? Is it food? And I guess that, of course, the idea is that the best choice is always going to be based on that particular context. If we all have the same idea in mind, which is that we want to ensure that a population cannot just access food, but quality food and nutritious food, then we need to think about this healthy diet. And we need to think about, first of all, getting the analysis and make sure we're tracking the change in costs of these diets, and then looking at different options. Unrestricted cash transfers in DRC is something that we're doing because the markets are functioning, but people simply don't have the money. Fresh food vouchers are something that we use in Ethiopia, which is part of a social safety net project that allows people to access higher quality foods than they would normally be purchasing. We have direct food distribution in Cox's Bazar, where refugees are living who are highly dependent on receiving their food from an external source where economic opportunities are too limited. School food take-home rations is happening all over the world, where in most places governments are leading, but they are using the school food as a way to ensure that at least certain members of the family are getting that one meal a day that so many hundreds of millions of kids are dependent on around the world. And then finally, none of this works without social and behavior change communication. What does that mean? That's simply talking about the fact that, as we know for COVID, wash your hands, stay a meter apart. These are social behavior changes, and the same thing needs to happen with the diet. We need to ensure that we are encouraging consumers, that we're helping to educate consumers so that consumers can demand nutritious foods and be able to feed their families when they have the means to do so. And also to make sure that there are nutritious foods available in the market. Okay, I know time is short and that was a lot, so I'm gonna leave it there so that there's enough time for questions. Maya, back over to you.
Yeah, thank you very much, Alison. So please put your questions in the chat box and we will deal with that after the next two speakers. I will now introduce Ms. Alexandra Ruteshauer Pereira. She's the head of nutrition of Action Against Hunger in the UK. Alexandra has been working in the humanitarian field for the past 14 years, and she focused on public health nutrition in emergencies and development in more than 20 countries across Asia and Africa. She's worked for various NGOs such as MSF, IMC, and Save the Children before joining ACF, of Action Against Hunger UK. Welcome, Alexandra. You will be presenting some tools that have been developed to overcome the challenges faced in the monitoring the nutrition situation in the context of COVID-19. Please go ahead.
Thank you very much. Hi, everyone. So indeed, we've seen over Maya's discussion and Alison's discussion, we know that COVID-19 is a health issue, but it will not only affect health. Maya spoke about the different spheres that will be affected, such as the political, social, economic spheres. And Alison just mentioned all the impact it will have on food security. So if we have such an impact of all of those spheres and food security, that means that we know that the nutritional status of the population will be affected by the situation, either by the disease itself, but most likely, as we've seen, by all the consequences of it, of the lockdowns and the fears of it. So if we have a deterioration of the nutritional status of the population, we need to be able to measure this deterioration. If we are not measuring it, we will not be able to allocate resources needed to prevent and treat malnutrition. We will not be able to plan the products for treatments or for prevention. We will not be able to plan for essential drugs or for the human resources needed to cope with the increase of malnutrition. And the problems that we are facing now with COVID-19 is that we are not able to survey the nutritional status of the population in the same way that we were able to do it, simply because all the measurements that we make to measure the nutritional status of children, they are called anthropometric measurement. It means taking the weight, taking the height, checking for bilateral edemas, or measuring the mid-upper arm conformances of the children. All of this means that we have to touch the children, or that the health workers have to touch the children. And that's deemed impossible in the context where we have lockdown, at least to do it in the community for surveillance. So we need to find another way to do it. I am part of a group called the Global Technical Assistance Mechanism for Nutrition. So there are three working groups on that group. There is a wasting one, infant feeding in emergency, and the Nutritional Information System, of which I am the co-chair. So this group very quickly, with the crisis, highlighted in April already that we will have to find other ways to do surveillance and monitoring of the nutrition information. Some of the recommendations that they came up with in their guide is the fact that, one, we need to maintain physical distancing and use alternative ways of surveilling the situation. Two, we need to coordinate any nutrition information activities that are already ongoing. Three, we need to maximize the utilization of existing data and information system. And then finally, there's no point in collecting information if you are not sharing it. So you need to make sure that those information and those reports are relevant and they are also easily accessible for others. So I want to come back on the first point, which is maintain physical distancing and use alternative ways. So before even COVID-19, within Action Against Hunger, as we are quite specialized in nutrition information with nutrition survey to look at the prevalence, coverage surveys, or even surveys to look at the causes of malnutrition, we knew that we really need to try to make sense of all the different innovations and tools that are available out there to collect nutrition information. And that was before COVID-19 that we had actually the idea of these documents, because there are so many things out there, we just couldn't make sense of it all. So we published this review. You will have the links for all the tools that I'm sharing with you on this talk. They will be on the slide, but we are also sharing them on the chat box. So this tool, I thought I would share it with you because I think it could be interesting for you. It certainly was for our missions to look at what's available out there that can be used to use alternative ways of doing surveillance. Some of them that are including in the reviews are still at research stage, but they are important to know and to follow. And one of them, for example, is called the SAM, for Severe Acute Malnutrition Photo App. And this is an innovation that will allow us to take pictures of children and have community health workers, mothers, taking pictures of the children to be able to look at their nutritional status. So we won't have to touch them. Unfortunately, it's not ready yet, but we can see how these type of tools are important in this type of context. And the last document that I wanted to share with you as well during this talk is a surveillance system guide that we developed for our missions, but made available for all external actors that need it. It's available in English and in French, and you will have the links for it. And this guide is really to tell us that, okay, it's impossible to take anthropometric measurement or even to make community assessments to gather information. So we need to look at non-specific nutrition indicators. We need to look further than just taking a measurement of the children to evaluate what is the nutritional status of the population. And this guide that I'm sharing will help either to cover the gaps of some surveillance that are in place, or can also allow to put in place a full surveillance system. And some of the indicators that I wanted to share with you that are part of this guide and that are deemed essential, you have obviously to follow what are the cross-cutting issues, such as how people are restricted in their mobility. That will be crucial to know how much all the systems will be affected. We know also from the lessons from Ebola that when we have such a situation, we have huge consequences on utilization of primary healthcare products, primary healthcare services, and nutrition services, which are essential to women and children. And so it's really critical to monitor what is the utilization of health and nutrition services. Have they decreased or have they increased? Because it gives us a lot of information. Alison mentioned food security. I wanted to mention also mental health. The situation is increasing the level of stress and anxiety in the population. And therefore, it's critical to also measure the services available for mental health and psychosocial support. Regarding food security, again, Alison touched upon it, but it's really crucial, as she showed the example of Afghanistan, to look at what was the status of the initial food security situation before the COVID-19 situation, and also during the situation, during the crisis itself and any lockdown. What is our household food security? So you can look at scoring the diet diversity of the families. You can look also at what are the coping strategy they are using. And then finally, another essential indicator really for us was looking at access to water, especially if people are quarantined, because we know that water and sanitation is also a very important sector in this pandemic. So really, the idea of this guide is to survey the evolution and the effects of the pandemics. And community assessments could, for example, be done by phones. There can be bias that you need to avoid for this. But this guide is also giving us some tips on how to do community assessment by phones. And then finally, the GTAM, the Global Technical Assistance Mechanism for Nutrition that I mentioned earlier, is developing additional documents. So stay tuned on the Global Nutrition Cluster website, because you will have a lot of those new tools and guidelines coming up fairly soon. Thanks a lot.
Thank you, Alexandra. It's a very useful list of tools. I would like to introduce our last speaker. That's Kate Golden. She is based in Beirut. She's a Senior Nutrition Advisor for Concern Worldwide. And she has been working on nutrition programming for 15 years, and she's worked in Ethiopia, South Sudan, and Lebanon. And since 2006, she has supported nutrition programs and emergency responses in many countries across Africa and Asia as a global nutrition advisor. Thanks, Kate, for being with us. Kate will provide insights on the impact and challenges of diagnosing and treating acute malnutrition during the COVID pandemic. She will share some examples of how Concern Worldwide and other actors are adapting to address them. So please go ahead, the floor is yours.
Thanks, Maya. Sound is good, yes?
Perfect.
Okay. Yes, so as Maya said, I'm going to focus on the treatment of acute malnutrition. So those are children who are wasted or too thin because they've had insufficient food or a recent bout of illness, or very often both. So this is kind of the far end of what Alison was talking about in terms of rising food insecurity. It's also due to illness and has fatal outcomes for many children around the world. At any given time, there are approximately 50 million children under the age of 5 in this condition, and 17 million suffer from the most severe form of wasting. And just to put it into perspective, children with severe wasting are roughly 9 times more likely to die than a child who is well nourished. Fortunately, there is a relatively simple and cost-effective treatment for this condition that has been globally endorsed and is included within national protocols in most of the countries where acute malnutrition is a public health problem. And it's called community-based management of acute malnutrition, but I won't expect you to remember that. Unfortunately, it's estimated that only about 20% of these children who were wasted actually accessed treatment in 2019. That leaves about 40 million children at huge risk of death or more permanent forms of malnutrition or disability. And while we've made remarkable progress tackling acute malnutrition over the last 20 years, there's still much to be done. And now COVID-19 has introduced a new wave of challenges. So I'm going to outline a few of those challenges briefly, and then give more detail on just one example of an adaptation to programming to cope with COVID-19. So before I start, what you really need to know about how we treat acute malnutrition, I'm going to give you the extreme basics. So there are two essentials, and these were fundamental to transforming the way we treated acute malnutrition about 20 years ago. There was a huge breakthrough. So as I said, I won't go into the details, but the first thing you need to know about, and because this is also the basis of many of our innovations with COVID, is the critical importance of community mobilization, community level screening, and this mid-upper arm circumference band, known in short script as a Nuoc band. And this band is used to measure children just in the middle of their arm to determine if they are acutely malnourished, and they get referred onwards and they're treated in a timely fashion. The second thing you need to know about is ready-to-use therapeutic food. So this is the ration that's given to children. They're usually prescribed to eat about 3 a day. And in addition to having their underlying illnesses treated, they will take that ration home, bundle it up, eat it mostly from home. There's very little risk of contamination, even in poor hygiene conditions. And the children usually recover in between 6 to 8 weeks. And so these two, as I said, these two aspects of community-based management of acute malnutrition, or the treatment, really helped us in the original transformation from a highly medicalized, inpatient-based approach to a much more community-based and more effective treatment model. So coming to COVID-19, there are many challenges that COVID-19 has thrown up for us, but I'm just going to talk about two. The first is that we really need to balance the health risks that COVID-19 presents against the normal mortality risks that children face every day in these settings. So I'm talking about children who in normal circumstances are dying from acute malnutrition, malaria, even measles, even simple diarrhea. And it's particularly important to keep this balance in mind, and for us as programmers to try to work with ministries of public health and policymakers to do the same, knowing that COVID testing levels are going to be low, probably in these settings for a very long time. So Concern's priority has been to help national governments and health staff to take this balanced approach and to advocate for them to maintain essential health services, especially for children under 5 and women, while taking the necessary precautions to keep staff and other health service users safe. As is the case for other health services, which I imagine have or will be presented in this webinar series, adaptations to malnutrition treatment protocols at health facility level have included physical distancing, which you saw on my first slide. It was women waiting at a distance of 2 meters with their severely malnourished children for treatment outside of a health facility, stepping up all infection and prevention control measures, separating suspected COVID cases and referring them onwards for COVID treatment, which is proving very challenging given that those referral pathways and COVID treatment centers are not always in existence. And then finally, simplifying our current treatment protocols as much as possible, to reduce the frequency of visits to health centers by, for example, doubling the ration, trying to move people quickly through the center or the health facility, and making it possible for staff and community workers with lesser medical qualifications to carry out and lead some of these tasks. There's still a question of how simplified we can get without doing harm, and those discussions are now very robust and active at the global and at the country level. And the second big issue for us is really, how do we find a way to continue this critical community mobilization, community screening, referral, and follow-up of children with acute malnutrition without increasing risk to the children, to the communities they come from, and to health workers and community health workers. So I'm just going to talk about one innovation which was in place before COVID happened, but is really starting to take off, and that's the family MUAC approach. And this is when mothers and fathers are trained and provided a MUAC band so they can regularly screen their own children for malnutrition, rather than relying on a community health worker to do so. For obvious reasons, a mother or a father have to touch their own child anyway, regardless of COVID. And so it's just empowering them, and at the same time reducing the number of people who have to touch that child or that caretaker. Studies have shown that mothers can use the MUAC and identify children with a high level of accuracy, at least as high as trained community health workers. And the family MUAC was previously known as Mama MUAC, but this has changed to emphasize the role not just of mothers, but of other family members in screening children in the household. Family MUAC was already gaining huge momentum before COVID as a way to improve coverage, so to shift our coverage levels up from that 20% that I mentioned in the beginning. And this is thanks to agencies like ALIMA and GOAL and others who have really been championing it and collecting more evidence on feasibility and effectiveness. This pre-COVID innovation now, however, has huge potential in the COVID era because it offers a low-touch alternative to what is ordinarily quite a high-touch screening process. Some of the challenges, so this picture here is of a mother in one of the health centers in South Sudan, in Juba, being trained. She was trained, and she's taking her own daughter's MUAC, and the same here. And this was from about 2 weeks ago. Some of the challenges are, however, that you need a lot of MUAC bands. Supply chains must be ready to supply them and deliver them safely to communities. And the supply we're seeing is already a huge problem in Cox's Bazar, where agencies are trying to scale this up, but the number of MUACs is a limitation. Training, mentoring, supervision, quality control via remote means or community health volunteers is still needed, but still a work in progress. And a number of agencies are looking at different apps and different ways that you can interact with mothers and community health workers who often have a low level of literacy. It's also quite difficult to start this process if you don't already have a strong foundation of mothers and fathers already trained in a community before movement restrictions or COVID-19 risk reared its head. This is a health worker training mothers to use MUAC with a doll. So this is something that has come about because not only to respect IPC, or infection and prevention control measures, but also because communities were saying, no, we don't want your staff, we don't want your community health workers coming to our house. So just quickly, for the moment, some of what concerns using family MUAC for. We are using it in most countries, we're using it inside the health facility during the consultation. So whereas the health worker, when they're doing the normal screening to either assess a child, to admit the child, or to assess their progress, they are training the mother or father on the spot so that they can do the MUAC measurement right in front of them. The health worker records it. The MUAC is either disinfected, very carefully disinfected, so used for the next patient, or where there are enough MUAC bands, that mother or father is given a MUAC band to take home and to monitor the progress of their child. This obviously is a bit of a slow way to scale up, teaching one parent at a time, and it also slows down the patient flow at the clinic, but it isn't ideal, but it is a start. In places like—
Kate, can you wrap up?
Yes,
yeah.
I have just one more point. So in South Sudan, where we're also expanding family Nuoc to children outside the health facilities, as I said, we're trying to do a cascading cascading approach where we can get people to receive the Nuoc and then have some technical support through rural through phones. And one thing that we think would be promising is in urban environments where mothers tend to be more literate and have more access to telephones, that we hope that this will prove successful, and we're scaling it up in Nairobi as we speak.
Thank you, Kate. Thank you
Thank
very
you.
much. So we have 15 minutes for questions and answers. Some are in the box. Sarah, you have the floor to lead the session of the Q&A.
Yes, great. Thank you, everyone. Thank you to the presenters for those very good presentations and to get ourselves thinking about the next impact of COVID. We had a few questions coming through the chat box, so I'll go ahead and ask them from our audience. The first one is just to get a broader sense of things. There were some questions at the beginning for Alison around the statistics and the information that you were sharing. Would those be applicable across sub-Saharan Africa? There was some comment as well about similarly challenging situations facing West Africa, as you had mentioned for East Africa. So how applicable are those circumstances beyond East Africa?
Yeah, thanks, Sarah. I don't have that data right at my fingertips, but what I will say is that the fundamental structural issues that East Africa is facing around conflict, drought, recurrent shock, economic disparity, a very much large number of people that need to work a day to eat a night. I think that those are all shared issues that are across the continent. Obviously, in some contexts more severe, and in other places, yes, less. So I think that in sub-Saharan Africa, and I'm sure you know better than I do, Doctor, that you're seeing very, very similar outcomes, because I think a lot of the stressors on the population that have fundamentally based in poverty are the same.
Thank you, Alison. And another question around the double burden of malnutrition. So are we seeing similar impacts both on, we've focused in this presentation around severe acute malnutrition or acute malnutrition in general, but what are we seeing in terms of double burden?
Again, it's early in the COVID crisis to really have like good indications in cohort studies. But what I will say is that anecdotally, especially in the Panama region and in places in around Southern Africa and even in parts of Asia, we are hearing many, many reports of real changing availability of foods. And what we're seeing is a lot more ultra-processed foods that are in the markets as opposed to fresh foods. And I think that most nutritionists will tell you that that is a real red flag for potential double burden, where we have many, many malnourished, wasted, or stunted, but we also have these problems of obesity and overweight because of diets and because of food availability. And that does seem to be shifting, and that seems to be a global phenomenon with COVID-19.
Thank you for that. Another very interesting question from the audience was specific to gender. I wonder maybe Alex could take this question in terms of how can we keep gender dimensions and considerations in mind.
It's a really interesting question, because although once again, as Alison mentioned, it's a bit early to have all those information available, but what we know before COVID-19, so we do a type of survey called link nutritional causal analysis. It's both a qualitative and quantitative type of study that takes quite long. It takes 4 to 6 months, because we spend quite a lot of time in the community. And already most of the causes of malnutrition that we find is due, and in several different countries and parts of the world, to women's workload and the fact that they have way too many things to do and are not able to have the care practices that would be the best for the child to thrive. So you can imagine that indeed in the context of COVID-19 and in the context of lockdown, in a context where also sources of livelihood might be affected if people have to go outside to sell any types of product, that indeed the gender dimension would be really, really high. I mean, I live in England, and I see it, and we know that there is a big gender imbalance in the consequences already of COVID-19 here. So we don't have the data, but it will certainly be very, very good to look at it, because it will definitely be a gender imbalance there for sure.
Thank you, Alex. We also had a fair few questions around supply chain for RUTF, as well as in terms of, Kate, you mentioned the difficulties of the number of MUACs that would be needed to implement mother-led or family-led MUAC. So one question on RUTF supply chain to any of the presenters, and the other question on local production of supplies, for instance, the MUAC tapes or other things. We're seeing this with face masks, for instance, and linking it with livelihoods programming as an option.
Do you want me to take the MUAC first? I don't
Sure.
have a lot to add, to be honest, but that question has come up a lot in different countries about could we make a locally made MUAC, even kind of a disposable MUAC if we had to. I think there are some initiatives. I mean, I think we generally look to UNICEF because they have some of the strongest supply chains. They should be able to get it out. And what we've had feedback from UNICEF saying that actually it should be working fairly well. It's just maybe more the transport chains. I can't point to any specific examples of locally made MUACs, but yeah, I think people are looking into it because obviously it's a very simple technology that should be durable enough for a mother to take home and use multiple times, but it should work. And then on the RUTF supply chain, UNICEF is definitely looking at this. A number of NGOs led by Alexandra actually have been in touch with UNICEF. They feel fairly confident that the production is up. I think it's more around the transport again. I don't know, Alex, if you know anything else, or Alison, about, without UNICEF on the line, at least I don't think they're on the line, about actual RUTF projections and who's looking at those sort of that modeling.
Yeah, so I know, like, yeah, we've seen the answer as I did. I don't have more information, but they're definitely looking at securing more supply. Although we were not sure about the fact that the production could be increased, and I think that was a worry for us. Technical experts in the NGOs that ask UNICEF about it. There is supply available for the next 3 months, but that's assuming business as usual, and we don't think there will be business as usual. So we are indeed slightly worried about what's going to happen in the coming months, because right now what we need also is for the production to increase.
And if I can just make one more point, just about what we're seeing, and I think there's a risk that at the moment we're seeing in a lot of our countries, the number of children being brought to the health centers is actually going down. And I think we have to be really cautious about taking that as meaning that, you know, COVID is not having an impact, that people are fine. I think parents are afraid to bring their children. There are lockdown complications, complicating movements. So I think we cannot be lulled into any kind of false sense of this all going to be okay and we can just skate through with our normal supply of our RUTF. I think we need to be prepared for huge spikes. We just don't know exactly when they're coming. But I do understand that Johns Hopkins and UNICEF are engaging with a number of partners to kind of model different scenarios based on existing data to see what the caseloads might look like. I don't know if anybody there knows any more about it, but it's promising, and hopefully that will help us to plan better the RUTF supply chain.
Maya, do you have anything to share on that modeling?
No, not this, but I can ask Paul later who will have the last word from this session. So whether he...
Great. And although the question focused on ready-to-use therapeutic foods, I'll just also open it up to Alison in terms of the ready-to-use supplementary food pipeline. Are there any, is there any information that you might have on how that pipeline is being impacted?
Yeah, I mean, it's very much like Alex said. We have sort of this guaranteed 3-month window, but it's a fragile pipeline, because even though there's producers globally, you're never sure where the raw materials will be available, and you're never sure whether or not shipping and flights are going to be disrupted. But I would say that you know, UNICEF, I think, has something like 21 local producers that they have supported over time. And the idea for both WFP and UNICEF is that there's a really diversified food base for the RUSF and the RUTF. So at the moment, we don't project as WFP any shortfalls, actually, even with increasing numbers, because we've padded our numbers. Even though I take Kate's point, it's sad, in many places the numbers are going down, not up. We still think there could be a spike in numbers before the end of the year. But I think that the most important thing is that we're looking at global consumption together, and that we're sharing that to make sure that if there is supply, there's only a certain number of suppliers, and that there's no stockpiling, but there's an ability to move that around where the need is greatest.
Thank you for that, Alison. We're coming close to the end here, so I'll just ask one final question around prevention. The question came up of whether we would consider lowering the threshold for programs such as blanket supplementary feeding to try to prevent some of those spikes of malnutrition, or some other ways that we might adapt our prevention programming. Sure. Yes, Alison.
Sorry, I wasn't sure, because I'm sure anyone can speak about prevention. Absolutely, I think it's a really valid point. And I think that the first thing to say is that, yes, the use of a nutritious product like a blanket supplemental feeding program is one model, but it is one model. And at the moment, there's not much need to lower a threshold, because the threshold for a true prevention program is usually an age range, right? So children, say 6 to 23 months, and in acute crises, that can easily be extended to 6 to 59 months. But the other important group in that are the pregnant and breastfeeding women. So we have these two groups, and I think that in terms of threshold, what I'd like to raise, that the real issue is that prevention is really key right now, and we need to all be working together to also figure out about getting donor money. We find that it's easier to get money into treatment than it is to get money into prevention. And we know that prevention is far more cost effective, right? Every dollar spent on prevention really yields a $16 return. We know this. We know that there's massive returns, but this is something that we all need to work together to talk about the importance of prevention. And again, not just BSFP, but everything. Immunization, primary health care at the community level, counseling and interactions with the families, especially around healthy diets, is something that we think we need to do together.
Great. Thanks for that, Alison. Apologies that I won't be able to get off to all of the questions, but thank you everyone for such an active chat box and all of your questions that you've submitted. I'll hand over to Mija to close.
Yeah. And thanks to all the presenters. It's clear that we are still in a great crisis, certainly with regard to food security or insecurity and malnutrition. We need to prepare, we need to prepare better and remain innovative and creative in solutions. The last few seconds will be given to Paul Spiegel, Director of Center of Humanitarian Health at Johns Hopkins, for a few words.
Excuse me. Hi, everyone. Thank you very much, Mija, Sarah, Alison, and Alex. Much appreciated. Just to say that next week's session will be on surveillance in COVID and humanitarian emergencies, and the moderator will be Oliver Morgan from WHO. And as Ryan had mentioned at the beginning of the session, we will be extending this, so we will have 4 more sessions after the surveillance session. One of them will be on maternal child health and COVID, but we'd love to hear your suggestions as well. So please feel free to contact us. Thank you, and have a good day, everyone.